This conference will now be recorded.
Assalamu alaikum wa rahmatullahi wa barakatuh. In the name of Allah, we'll start the sixth session revision for September 2020 exam. Please, throughout the session, try to mute yourself because we don't want to waste much time asking you, and also to mute yourself from my side. Also, it takes time and also will waste much time. So please keep your camera and your mic closed all the time. Please, no questions in between. In the end of the session, we will open a discussion. I wish you finish the first 5 sessions. I posted all in YouTube. It's a very important sessions for the exam. Try to revise it and repeat it frequent times. Today, we will start a very important topic for the exam, reducing the risk of thrombosis. In the exam, usually, you can face EMQ 3 questions regarding this topic because this is very important and very vital for the exam to revise this guideline. Guideline huge. If you look, sometimes even after you finish reading, maybe you fail to answer even the question. You need to practice how to concentrate in the important informations in the guideline and how to solve the questions. Today I prepare about 50 questions. Each questions carry an idea. Some questions, tricky questions, you should be careful before you answer, and we will know how we can answer in the exam in wrong way. And after this, we will ask why we failed in the exam. It's better to give a chance for who didn't share before. It's better to take candidates who are preparing for September exam. If not, so we can take who will be February or who didn't share. If not, so who shared before. Today, reducing the risk of venous thromboembolism during pregnancy and puerperium. And we know that pulmonary embolism remains a leading direct cause of maternal death in UK. I think Dr. Sumaya, you text me. You are for September exam. Dr. Sumaya. Dr. Sumaya, you text me on Telegram.
Yes.
Dr.
Assalamu
Sumaya,
alaikum.
you are. Alaikum assalam wa rahmatullah. Each candidate, he will take 10 questions. Be careful. All of you also, you should sync with who is answering the question. So you will secure also level. Okay, Dr. Sarah. So we'll take Dr. Sa, Dr. Sa, your name, Dr. Sa, after Dr. Sumaya. Okay, Dr. Sa after Dr. Sumaya. Each candidate, he will take 10 questions. Okay, start. Dr. Sumaya, you are here?
Yes. Patient in ANC, you decide to give her low molecular weight heparin. According to her risk assessment, she asked you how much percentage that low molecular weight heparin will reduces VTE risk. Ask you.
Okay. One patient, you are in the clinic, you are going to give her low molecular weight heparin as a prophylaxis during a pregnancy, for example, and she tell you, doctor, so how much chances this will decrease the risk of venous thromboembolism?
It's 60%.
60%. Correct. So it's a correct answer. If patient for surgery and you are going to give her prophylaxis for surgery, so it will decrease the risk by about 70%. This is very important. Don't think that if you are giving the heparin, that this will be 100% protection. Be careful before answering the question. Excellent. Next.
It is actually my net may be slow. It's coming a little bit late.
No problem, because there is no problem. No problem. It's
now I can
updated, but
see it. Yes, now
okay.
I can see. Pregnant
Take your
patient with history of one previous VT given low molecular weight heparin. She asked about how much percentage low molecular weight heparin will reduce the risk of VT in current pregnancy. So she got low molecular weight previous due to VT, and now this is in current pregnancy. She will again it will reduce her.
So here's the patient already, she has already one venous thromboembolism in the previous pregnancy, and you are going to give her the low molecular weight heparin.
Yes.
So she asks you how much chances this will reduce the risk of venous thromboembolism.
It's B.
B, 88%.
Yeah.
Correct. Excellent. So if the patient has history of venous thromboembolism in obstetric patient, if you are going to give her heparin, this will decrease the recurrence of thrombosis again about 88%. When you are doing assessment of the risk of thrombosis, it's better before the pregnancy. It's better if you will not see the patient pre-pregnancy, so you can do in the early pregnancy, in the start of her pregnancy at booking a visit, on the admission. If she admitted to the hospital, you need again before discharge from the hospital. If the patient prolonged admission more than 3 days or more, intrapartum, you need to again to do assessment of thrombosis again and postpartum. Or develop any reason, maybe if suddenly during a pregnancy she developed any other surgical problem, so need again assessment. Excellent. You can
it
see
hasn't
this.
appeared. Yeah, no, the screen has not yet appeared.
Okay.
Now it came.
Yes, it's there.
Risk of VTE during pregnancy is highest in it's postpartum. I know this.
Highest in the postpartum. Yes, correct answer. It's about, it's five-fold higher than antepartum, and it's more in the first 3 weeks postpartum. So it's highest in the postpartum, especially in the first 3 weeks, and this will be five-fold more than antepartum. Okay. Well done, Dr. Sumaya.
A 36-year pregnant, 27 weeks women. 36-year, 27 weeks.
This
Women
is not
previous vaginal
Dr. Sumaya.
delivery.
Yes.
BMI 40, hypertension on treatment, blood pressure 130/80. So low dose heparin start it's C, simply C, because yeah, BMI is the risk factor and previous 3 multi.
So tell me the score. How you are doing score?
Score is 2 and 3. 3, 4.
How
Age
so how much is the score?
4. Age
4.
36. Yeah.
36 1.
Age multi
Age, para 3, and BMI.
Please,
and
please don't
BMI.
interrupt here. Please don't interrupt here. Please, no interruption, please. Dr. Sumaya, please continue.
Yeah.
Dr. Sumaya, age
Yeah.
36 1. Okay.
Yeah, 1.
Then
parity 3.
Talk, Dr. Sumaya, where are you?
Yes, I'm here.
Okay. Yes, okay. Then which one you give score again? 1. Which one? Talk.
Yeah, it's parity.
Parity 1.
Yeah.
Then
yeah. And
then
BMI 2. BMI 2.
2. So it's a total 4.
Yeah.
Okay. Excellent, Dr. Sumaya. But I wanted to tell you something. I will tell you something. In the exam, you have 200 questions, correct? 100 in the first page and 100 in the second page. So the examiner will not tell you in the exam, take care, this is the question of thromboprophylaxis. He will not tell you like this in the exam. He will not tell you. Will be a question in between. And some they are seeing the patient hypertension and aspirin. They are under the tension of the exam. They are not carefully regarding that this is patient score 4. So if you answer any question, just look again to the other options. So why he put low molecular weight heparin?
Yes.
So again, go up. How much is the score? Aspirin for prophylaxis. You wanted to prevent. So it started from 12 weeks. So if you wanted to start, it should be at 12 weeks. But the problem in the exam, he will not tell you this is a question of thromboprophylaxis. Take care. And some you will be sleeping in I will be sleeping in the exam. I will not concentrate. So be careful. If there is one patient pregnant, low molecular weight heparin, just look again about the score. So this one score, this patient should start low molecular weight heparin. Excellent,
yes.
Dr. Sumaya. Excellent. This is the score. We will practice now how we are going to do scoring. So don't worry regarding the score. Well done, Dr. Sumaya. So we are going to do scoring later.
Question number 5. Risk of antenatal VT is the highest in first trimester, second, and third. It's first trimester, antenatal.
First trimester, this is the old guideline.
Okay.
This is the old guideline. In the old guideline, yes, you are correct. It was much of the venous thromboembolism, but the recent guideline. It's wrong question. This is the third trimester. This is the recent study. The recent study shows that the risk of thrombosis will be highest in the third trimester. First trimester, this is in the old guideline.
Okay.
Okay, so the one we are going now to talk about the risk assessment of venous thromboembolism. If you have a question and you are going to give a score. So if the score 4, you are checking, you are talking about patient antenatal or patient postpartum. So if the score 4, the patient, she will take low molecular weight heparin once she is pregnant, all through her pregnancy and postpartum, 6 weeks. If the patient score 3, she will take from 28 weeks and 6 weeks after delivery. If the patient postpartum patient deliver, if the score 2, she will take at least 10 days. But some patient could be 3. Be careful. We are talking about postnatal. Postnatal, maybe there is another risk factors. Patient now 3, still this patient she can take 10 days only. So don't confuse. If you are seeing one question, the patient postpartum and the score 3, she didn't receive any low molecular weight heparin during the pregnancy, so this patient could receive also 10 days. If score 1, this is just hydration. Patient should be early mobilization and hydration. Will be avoid dehydration because this will increase the risk for her for thrombosis. We will practice now how to do scoring. The idea from in the exam, how you are going to give a score in each case, and be careful. There will be a tricky questions.
It's not appeared yet. The next slide. Yes, it has come. 42-year gravida 4, para 3, 13 weeks, smoker. Previous all vaginal delivery. No family history of VT. What advice you will give to her regarding VT prophylaxis? The score is 1, 2,
I want to
and
tell
3.
you, no, because there is some you don't know how to do scoring. So please, when you are solving this question, just you will mention how you will tell by age.
Okay.
This would be like this, okay?
Okay. So for age is 1.
Why
It is
1?
more than 35. More than 35.
Okay.
42.
Okay.
And parity more than 3.
Okay.
And she is a smoker. That is 1. So each
More
is
than
1.
3 or 3? More than 3 or 3?
3.
3. Okay, so 1.
Yeah.
So now we have 2.
1.
Then
smoker. She's a smoker. For that she gets 1.
1.
Yeah. So
Okay.
in this case, antenatal prophylaxis will be started from 28 weeks onwards. So
28
here,
weeks. So
yeah,
E, correct?
yeah, E.
Yes, you are correct. So we are going to learn. If you are solving a question regarding thromboprophylaxis, just you should learn how to do score. So if the age more than 35, the score will be 1. Parity, para 3 or more, score 1. Smoker, score 1. No family history of thrombosis, it will be 0. So 3. So 3 from 28 weeks and 6 weeks postpartum. Okay. Next.
Keep coming. "35-year primigravida, IVF
Okay.
pregnancy, twins 10 weeks, no family history of VT. What advice you will give regarding thromboprophylaxis?" So here, for age, she doesn't get any score, and IVF 1, and for twin 1. Can you hear me?
Yes, yes, I'm following you. Yes, I'm following you.
Mm, so score is 2. For 2, uh,
Okay.
accidental prophylaxis, it's D, 10 days. Antenatally, we will advise her to mobilization and avoid dehydration. And postpartum, as score is 2, she will get
No, no. Okay, just this is a tricky questions. I know it's tricky questions. This is can happen in the exam. So 35, be careful. I just put 35 because I know some they are giving you one score. No, he put in the guideline more than 35, score 1. So 35 age is 0. So correct, Dr. Sumay, because some they are writing in the chat should be 1. No, more than 35, more than 35. So this will include 36. 35 will be 0. IVF score 1 during antenatal. During antenatal, if you look here,
okay, I got it. Yes.
where where is I wrote, it's not here. I didn't put here.
But IVF
Yes,
is there.
yes, obesity, not this one. Where is I will show you later. I will maybe in the next slide. Okay, IVF is a score 1 during antenatal care. Score 0 postpartum. So if this patient, we are telling now that we are not going to give, we are going to do, no need, it's just, it's the same. Sorry, B and E same. No need for thromboprophylaxis, so it's the same. Sorry. So B and E, it's similar. Okay. Just I don't want it to open again and remove. We can remove now, so it will not appear in the PDF. What is I put the answer? Which one? The problem I put E. Okay, no problem. I can remove B just to not make you confused during answering. Okay.
Yes.
So if
So
this
from
patient during,
postpartum, IVF is not counted. So the score will be 1.
yes,
Okay, I
yes.
got it.
So this patient during antenatal care, her score will be correct too. You are correct. It was 2. But the answer you choose postpartum 10 days. So in postpartum period, this patient, the score will be 2? No, the score will be
No,
1 only. Why? Because in IVF, during a pregnancy, it will be 1. But postpartum, it will be 0. Just this is a tricky question to be awake carefully before you answering any question regarding thromboprophylaxis. Okay, clear?
clear.
Okay, next.
35-year. Is it the same question? No,
Uh,
here it says
I
post-vaginal
don't know.
delivery.
Okay, look again. See,
No,
see.
no.
I put it for idea also, for another idea.
Yeah, yeah.
But just answer the question.
35-year primigravida, IVF pregnancy, twins, post-delivery post-vaginal delivery, no family history of VT. So here, uh, score is again 1.
1. Okay. So what is your answer? So what is your answer? What is your answer? Okay.
Answer is early mobilization and hydration.
Yes, excellent. In the exam, be careful. Yes, could be there is answer, no need for thromboprophylaxis. Yes, you will not give score 1 thromboprophylaxis. But in the patient postpartum, if you find early
Yes.
ambulation of the patient, mobilization of the patient, and hydration sources will be better option. You think how you are going to answer the question. So if no need for thromboprophylaxis, you can choose. If more answer more better, especially in the postpartum time, you will choose early mobilization of the patient and hydration. So this is
Yeah,
a correct
postpartum,
answer.
she's twin pregnancy, postpartum risk of thromboprophylaxis is high.
I want from you,
And
before answering any question in the exam, if you choose one answer, just look again in the other answer, because sometimes when you are looking to the other answer, you can recognize what is the tricky, what is the problem in the question. Like the patient, the first one I post, the one with the score 4. If he put low molecular weight heparin, so I will remember the thromboprophylaxis. I will look again the scoring, because in the exam he will not tell me this is the question of thromboprophylaxis. You get the idea? So if you
yes,
answer any question, just look again to the other answer given in the question. Question number 9.
35-year primigravida IVF pregnancy twins delivered today by elective cesarean section. No family history of VT. What advice you will give regarding VT? So here again the scoring will be only for twin and elective cesarean section. That will be 2.
Yes, again, 35 0, because we tell the age, just we want to practice, just to practice.
Okay.
So try to practice by this way. 35, it will be you in the exam, especially now computerized, but in the exam, if it is paper, we are writing 0 up, because this is 35 only. IVF in antenatal, it will be 1. Postpartum, it will be 0. Twins 1. Elective cesarean section 1. So the total score will be 2. So what is your answer?
It's 10 days postpartum, 10 days VT prophylaxis.
So it's D.
D.
Correct. If you look here, I think it's here. Yes, you look here. IVF. You see this one?
Yeah.
Antenatal care only. But
Yeah.
if you are not understand what you are putting in the guideline, just you will tell IVF. It's a score 1. IVF is no. It's IVF antenatal care. So it's a score 0 in the postpartum. Okay. So next question. This is the last question for you.
Okay. 36-year primigravida, 12 weeks IVF pregnancy, twins, smoker. No family history of VT. So here 36 1 and IVF 1 and twin 1, smoker 1. So total score is 4. What advice regarding thromboprophylaxis? So this is A.
Yes, because the score is 4 here and during antenatal care. So this patient, you will start from the start of the pregnancy. And if you start a thromboprophylaxis for the patient, you start prophylaxis for the patient from the start of the pregnancy, because of her pregnancy risk assessment, you will continue for 6 weeks. So it will be antenatal care thromboprophylaxis. Sorry. The point here, the idea from this question, that this patient, Dr. Sumaya,
Yes.
this patient will come from 12 weeks.
Yeah.
Okay.
So
which one you choose? Sorry, because there is one message sent to me, so it's disturbed me. Sorry, what is the answer you choose, please, in the start?
In the
What is the answer
start, ANC thromboprophylaxis, but here from D it is said that
yes.
B.
You choose A.
D.
You choose A because the score is 4. This is correct.
Yeah.
But if you look,
more
this
correct is D.
Patient come at 12 weeks.
Yeah.
So the patient now you will start from her from 6 weeks. This is just playing by some words, but in the exam, could make you choose a wrong answer.
Yeah.
So thromboprophylaxis, no, it's not, A and D not same. Here, antenatal care from 6 weeks. From 6
Yeah.
weeks. In 6 weeks pregnant. She is now 12 weeks. So you will not start from 6 weeks. You get the idea?
Yeah.
When patient,
I get
the
the
patient
idea.
now, she is pregnant. Maybe she not come in the first 6 weeks, 7 weeks. She come when she is 12 weeks. So the first visit for this patient was at 12 weeks. So how you are going to start thromboprophylaxis for this patient from 6 weeks?
Yes.
Anyone have any solution? Anyone? So the A can't be options for the patient because the patient,
Yes.
she didn't come. But if she come at 6 weeks, no problem, we will give her.
Yes.
But in the question, he tell you the patient to visit you at 12 weeks.
12 weeks.
So how
from
you
that
give her
we start.
from 6 weeks? No, you will give her the more correct options because she will
D.
hear. This not means that the patient she will start from 12 weeks. She should start
No,
from
because
when?
she has come from that week. So after scoring, we'll start from that week.
From the start.
Yeah.
So doctor who was asking in the chat, if she come in from the start of the pregnancy, you will start from the start of the pregnancy because the score is 4. Okay, but the idea here in the question, be careful about the duration. Why? Because some questions is very tricky in this one. Like one patient, she come today to check her result about antiphospholipid. I think we discussed this point. She come today. You tell her that the antibody is positive. When she did the test, okay, you will tell her we need again to confirm after 12 weeks. But the patient, she already done before 12 weeks, so you will do today. So if there is option to repeat today, you will repeat today because the patient already takes the investigations about 12 weeks before. You get the idea or no?
Yes,
You
I
get
get the idea. Yeah. The
I hope
best
it's
is
clear.
D. Yeah.
When the patient, you see the patient, so this patient score 4. So
4.
when she should start the low molecular weight heparin from the start of the pregnancy, correct? But the options here, the patient, she come to me at 12 weeks. So which one will be correct? I will start from 12 weeks because the patient, she come today only. So I will start from today. But if she come from me from the start of the pregnancy, I will give her. Get it? Okay. So the question will be answer D.
D.
Thank you, Dr. Sumaya, for sharing.
Thank you very much.
Really, all the best for you in the exam. I think there is Dr. Sa.
Sana.
Sana. Okay, because there is no N in the chat. Okay. Okay, Dr. Sana.
Okay.
Question 11. Yes, it's like some tricky questions. Be careful before you answer because I just need to be alert. I don't want for me to sleep in the exam. I want to be alert. Okay.
Okay. 42 years old, hypertension in current pregnancy, para 2 plus 1, post delivery 10 weeks, history of stillbirth in previous pregnancy, smoker, previous all vaginal delivery, no family history of VTE. What is advice you will give to regarding VTE prophylaxis? Age 42, more than 35 when? Okay. Parity 0. Okay.
What is 0? What is 0?
Baratu 0.
What about hypertension?
Hypertension, current pregnancy, no, preeclampsia, not hypertension.
Okay,
0.
Okay, 0. Baratu 0. Then
Baratu 0. Stillbirth, post vaginal delivery 10 weeks, history of stillbirth in previous pregnancy, also 0. Previous.
So previous stillbirth is 0?
Yes, not current, not in current pregnancy.
Okay.
Smoker 1.
1.
Total will be 2.
2.
Okay. Antenatal prophylaxis starts soon as possible. No need for prophylaxis. Okay. Postpartum 6 weeks of delivery, cesarean section. She will take postpartum 10 days. Now no need B. Answer B.
No need now, but she
But
can
she will
use
take
postpartum 10 days. Yes,
yes,
but she will
yes.
need postpartum, correct? She will need no need
Yes.
now.
Now no
if no
need.
need for prophylaxis, so different, maybe need, but the most correct answer will be postpartum because the score will be still 2 after also delivery, correct? So D.
Yes. Yes.
Okay, but
Not,
I appreciate
B.
I appreciate the point is that you can do score stillbirth in current pregnancy 1. Some they are I will tell you because I am just if someone is reading the guidelines superficially, so stillbirth we can give 1. Stillbirth in current pregnancy 1. In previous pregnancy 0. Hypertension score 0. Preeclampsia 1. You get the idea? In the exam, don't worry, he will not put any questions with 2 answers. So don't worry regarding his answer. But if you do score in correct way, you will pass the questions. You will pass the questions 100%. So here, will be preterm also. If you have patient preterm labor, it will be score 1 also. I just want from you to know how to do scoring because it is very important in the exam. Okay? Okay. Next.
Okay, 20 years old, primary, 9 weeks, not a smoker, no family history. BT in current pregnancy, she admitted to hospital for hyperemesis gravidarum. Okay, what advice you will give her? 20 age 0, less than 35. Okay, primary 0. Okay, not a smoker 0, no family history also 0. Okay, hyperemesis gravidarum 3.
Okay.
She will start thromboprophylaxis during admission. The discharge she will not take. A.
So hyperemesis, this is temporary, something temporary. So once you admit any patient to the hospital with hyperemesis, she is a score 3. But this not means that she will take it from 28 weeks to 6 weeks. Be careful. There is some score 3, like the patient with hyperemesis, this will be temporary risk factor. Because once the patient stops vomiting, no more, the score will be 0. But now, if hyperemesis, she will be score 3. So once you admit any patient, and this is very important, even safety point for the part who are preparing for part 3 exam, if you are going to admit one patient, don't forget the thromboprophylaxis in the admission. Most of you will remember the antiemetic, but they will forget the thromboprophylaxis as a safety points. Okay, so she will start thromboprophylaxis during admission, and once the hyperemesis is resolved, so we will stop usually with the discharge. Body mass index, if the patient 30, it will be score 1, 30 or more. If it's score 40 or more, it will be 2. So 1 and 2 for the obesity. So 30 and 40. 1 and 2. Just to remember easily.
Okay. EMQ. Pregnant woman, smoker with hypertension, BMI 32, admitted for control hypertension. Okay. Smoker when? Smoker when? BMI hypertension 0. Okay.
Hypertension 0.
Yes. BMI 1. Total 2. Okay.
BMI 1. Total 2.
Yes.
Total 2. Okay. I'm writing with you. Okay. Then.
Okay.
So what is your answer?
Admitted for control of hypertension. Admission when? Admission more than 3 days when?
Yes.
Or she's in hospital.
Admitted. So she just admitted. You will give her 1. Just now admitted.
No.
Okay. So the total score.
Answer B. Total score 2. Even if total score 3 should be B. Answer B.
Okay, I agree for B. Okay, no problem. Yeah, we can make it B. Okay, no problem. Next.
Okay. Pregnant woman with antithrombin deficiency and previous history of DVT. Okay. This high risk. She will G. High dose antilatal low molecular weight heparin.
High dose. So which one? G or E?
G. High dose.
G. Okay. Okay. So 14 G.
15.
Okay.
Okay. With
Next.
deficiency brief. She will take therapeutic dose. Sorry, Dr. Ghada. Sorry, therapeutic dose. I changed my answer to E.
So you are in the exam. So you are in the exam now. You change your answer to E.
Therapeutic dose, but high dose. I want high dose for previous history.
So you need to choose one. No two options in the exam. I'm not giving the two options.
I will not change if no two option. Okay. 50. So I will not change. Okay.
So G.
31.
G.
Yes. 31 years old, post cesarean, BMI 30. I cannot see sick. What is? Please remove your.
31 years, cesarean section, post cesarean section, body mass index 30. 30, sorry, so 30 not weeks. Blood loss, but the answer will appear. I will edit later.
No problem.
I will remove the weeks, okay? But after the answer.
It is okay. Age 0, okay. BMI 1, cesarean. Cesarean when it is not mentioned elective or emergency. Okay. Blood loss more than 1,000 when score 3. She will take postpartum. D. Answer D.
D. Postpartum 10 days.
Okay. Patient with gross varicose
and 15. You give one score for again. You put post cesarean 1 and the body mass index 1, correct? And the blood loss 1. Okay, yes. So how much score? 3, correct?
Score 3.
So you are so you will give her D. You tell me D, correct?
Answer D. Yes.
Okay. Okay. Next.
Patient with gross varicose vein and venous delivery. Okay.
Now the meeting full. There is 250, so no one can enter more. Just I don't know, it's appear in the chat. Okay, I will. Okay, maximum now. Okay, because there is 200 now, 51, so no one can enter more. Okay. Okay, continue.
Okay. Patient gross varicose when venous delivery, instrumental delivery 1. Score 2. Okay. Also D.
Sorry, I will concentrate with you. Question 16. Gross varicose vein, how much is the score?
I forget it is antenatal or postnatal. Antenatal 1. Instrumental delivery 1.
Instrumental delivery, you are giving 2. You are giving the score 2.
Yes. D.
So
if varicose when postnatal 1. D.
So you choose what? You choose D?
D.
D? D, because you give, okay, D. Okay, let's see the answer. Okay. What? The last one?
D I choose before B. Early mobilization and hydration. Early mobilization and hydration.
B. Okay, so we'll check your answer. Okay, don't worry. Anyone in the chat tell I can't understand, please don't worry. The idea how you are going giving it to the score. The first one, you answer B. You answer B. What is the answer of B? Early mobilization. So why again we will check again the answer.
Smoker.
Patient hypertension, score 0, score 1 as a smoker. Body mass index will be 1, 2. This patient in the admission during antenatal care, she will not need any thromboprophylaxis, but after delivery, the score will be 2, correct or no? So still she needs for
Yes.
10 days only postpartum, correct? Because the score 2, correct?
Okay.
Next
Yes.
one, you choose high dose. Don't be confused. You are using only therapeutic dose for the patient with thrombosis. This is therapeutic. You are treating. Don't confuse. Therapeutic dose when patient already develops thrombosis. She has DVT or pulmonary embolism. So you are now treating the patient. So if you're treating the patient, you will give her admission more than 3 days. 3 days or more. This will be a score. But now there is no, just now admitted the problem every time okay. Score 1
Yes.
in the admission 1. No, if you have evidence just the patient admitted, she will take score 1. The one will be risk for the thrombosis from day 3 until the problem that there is much try to enter the meeting, but already the meeting closed. So this is closed again the screen here. I don't know how to stop this. Again, no, any one part of the confusion regarding admission. If you have evidence regarding just admitted, she will be score 1. The prolonged admission from day 3 or more, she will be risky for thrombosis. If the patient is antithrombin 3 deficiency, this will be high risk. I will not give her symbiotic. I will give her high dose. High dose, it will be how I will calculate the high dose. I will give her 50% or 75% of the symbiotic dose of the same weight. So if this patient weight like this, how much is the symbiotic dose? I will take from this dose as either 50% or 75%. This is what mean by high dose low molecular weight heparin. So don't confuse between prophylactic dose. Don't be confused regarding therapeutic dose. Don't be confused about high dose. Prophylactic dose, this is for the patient who will not be high risk for thrombosis. Therapeutic dose, if the patient she has now thrombosis, you will give her therapeutic dose. If the patient high risk, you will give her high dose. How you will calculate the high dose? The high dose will be only 50% or 75% of the therapeutic dose. The last one, gross varicose vein, it will be 1. It's not written antenatal or postpartum. It's only 1. If you look here, this is the gross varicose vein. It's score 1. Okay, so it will be 1 and 1, so it will 2. Ventouse, not mid cavity. If you look to the ventouse delivery, the instrument delivery, where is the instrument delivery? They are putting a specific instrument. I think the mid cavity and rotational. You look here, you can see this one. This one, will be mid cavity and rotational forceps. So this is just ventouse, so you are giving 1. So if he give in the exam mid cavity or rotational, or he will not make you confused in the exam. Don't worry. If he put there mid cavity forceps, put 1. If he put for you rotational, this is will be 1. Others, this means that this is not will be 0. Okay, it's clear. Don't worry. Just it's need repetition. It needs just repetition. Okay.
Dr. Gada, can I interfere?
Excuse me, Dr. Gada.
Dr. Gada?
Yes, I just want to ask one thing from you.
1 minute.
That
Give those 1 minute. Hello,
Okay.
Dr. Gada, can I talk with you?
No, just 1 minute. Just 1 minute. Please, anyone has any question, just put it in a small paper. In the end of the session, I will give you chance for all of you to ask. Please, just if you have any question, just in a small paper, just write your question and we will answer your questions. Okay? We will continue. Where are you, Dr. Sana? Dr. Sana, please. Dr. Sana. Dr. Sana, you are the one with me. Where are you?
Yes, 20 years old, primary. Hello.
Yes, I'm
20 years old.
Someone opening the mic, the session will stay like this. We can't every time we can't close every time or mute all the mic. Dr. Sana, please only open your mic.
Okay. 20 years old, primary, 9 weeks, severe ovarian hyperstimulation syndrome, not smoker, no family history of VTE. She admitted to hospital for ovarian hyperstimulation syndrome, received low molecular weight heparin, admission, and now for discharge. What you will advise? 20 years, 0, age, primary, 0, ovarian hyperstimulation syndrome, 4, not smoker, 0, no family history, 0. Answer E. Continue till 12 weeks.
Yes, if patient with severe ovarian hyperstimulation syndrome, how much is the score of ovarian hyperstimulation syndrome alone?
4.
4. Yes, so
Yes.
why you are not giving in all the pregnancy?
Because ovarian hyperstimulation syndrome only for first trimester.
Yes,
Just like hyperemesis.
This
Yes,
is temporary. Temporary. Okay, so be careful. Score 4. Correct. You are correct. But in the this will be temporary, like hyperemesis. So in hyperemesis, we are giving only during the admission. In severe ovarian hyperstimulation syndrome, this will be in the first 12 weeks. Other patient ovarian hyperstimulation, this will be individual assessment. So this will be severe ovarian hyperstimulation. The patient she will take during admission and first 12 weeks. So your answer correct. This is the ovarian hyperstimulation. Score is 4, correct, but she will not take in her all pregnancy. Be careful. She will take only during the first 12 weeks. In hyperemesis, score 3, correct, but she will not take from 28 weeks until 6 weeks. No, she will take only during admission. So just be careful. There is some score, and this is famous. So this can be a question, and you are going, this is ovarian hyperstimulation 4. Okay, so the risk of 4 I will give in all the pregnancy. Wrong, and you will fail in this question. Patient hyperemesis score 3, but you will give only during admission. So be careful. Ovarian hyperstimulation syndrome, this is increase the risk of venous thromboembolism, especially in the upper body. Body mass index 30 or more, 1. Body mass index 40 or more, 2. Just repeat. It's easy. Just need to repeat. Okay, next.
Okay. Barawen, post-vaginal delivery, BMI 4, according to the risk assessment, low molecular weight should be given. Okay. Barawen, nothing. 2 only. Score 2 because BMI 40. She will receive A at least 10 days.
Yes, if you have one patient post-vaginal delivery, her body mass index 40, this will be score 2. So the recommendation will be at least 10 days. This is correct. Be careful. Now we learn 35-0. 35 years, patient 0. 36, 1. Just I will teach myself like this. Bar 3, 1, and more. So it's easy, because in the exam, what happened in the exam? When you are seeing the exam, you will forget everything. It's 1 or 0. It's 1 or 0. You are talking to yourself. It's 1 or 0. So can't be. So you need to fix some rules. IVF 1 during antenatal care, 0 postpartum, gross varicose vein 1, stillbirth in current pregnancy 1, in current pregnancy, preterm in current pregnancy 1. Just teach yourself and repeat. It will be easy.
Okay. Sickle cell disease, post-vaginal delivery, Barawen, you want to give her low molecular weight, but you are not sure about duration of low molecular weight. Low molecular weight should be given for sickle cell disease for 6 weeks because she will be taking on antenatally. B answer.
How much is the score?
Score 3. High risk 3.
3. So you will choose what? Tell me what is your answer in the exam.
Vaginal delivery. Okay.
Close your camera, please, doctor. The record will be posted in YouTube. I don't know which doctor opened his camera, please. Okay.
But when you want to move her, okay. She will receive antenatally sickle cell disease.
Okay. So what is your answer? Tell me what is your answer in the exam.
B.
B. So your answer in the exam B. Okay, so score 3. Sickle cell disease score 3. So according to what we are telling, score 3 will take from 28 weeks and 6 weeks. No. In sickle cell disease, we tell that there is some patient with a score 3, they will take postpartum only 10 days. This will include the sickle cell disease. Sickle cell disease, they are given only during admission to the hospital. This is the sickle cell disease guideline, green top guideline. Sickle cell disease score 3, but they are not giving as outpatient. They are giving according to green top guideline if there is no any other risk factors during admission to the hospital. If the patient deliver normally, you will give her at least 10 days. If she delivers cesarean section, either elective or emergency, she will take 6 weeks. In the sickle cell disease guideline, they put if the patient deliver vaginally, she will take 7 days post discharge. Because maybe in the hospital, she maybe stay in the hospital 2 days. So it's 7 days, not from the day of the delivery. No, it's 7 days from the day of discharge. And in the surgery, cesarean section, they put 6 weeks from the surgery. So be careful from the words, because in the exam, if he give you a question from sickle cell disease and he put you a question and he put patient post vaginal delivery and give several options, heparin 7 days from day of delivery, heparin 7 days from day of discharge. You know that it's 7 days, so from which one? So it's 7 days from discharge, about 10 days. In cesarean section, 6 weeks from the surgery, not from the discharge. Some words, this is called change the answer. And after this, you will ask why I fail in the exam. Next. Next question.
Okay, yes, sickle cell disease, post elective cesarean, but when you want to give her low molecular weight heparin, you are not sure about duration. As you mentioned now, 6 weeks.
Yes, 6 weeks. Any cesarean section, sickle cell disease, elective emergency, 6 weeks from the day of the surgery. Thank you, Dr. Sana, for sharing. We can take another candidate. This is sickle cell disease. This is intermediate risk factors. This is a score 3. Yes, you are correct. Please close your camera. Okay, intermediate risk factor. This will be at least 10 days, including sickle cell disease. We need another. There is one doctor. Her name, Dr. Asima. She wrote her name in the chat. She tell I will set for September. Dr. Asima.
Yeah, I'm here.
Okay, welcome, Dr. Asima. Just a minute. I will. The problems with interruption. So this is what I mentioned, post discharge, and this one 6 weeks post surgery. Okay. Okay. Yes, Dr. Nikhat, you are the next. I think you put your name before, so you will be the next after Dr. Asima. Okay. You can see the question. Where are you? Dr. Asima.
Yeah, I'm here.
Okay.
Hereditary thrombophilia with highest risk of venous thromboembolism, factor 6 prothrombin, factor 5 latent mutation, prothrombin gene, and antithrombin 3 deficiency. It is antithrombin 3 deficiency.
Antithrombin D deficiency. But I find solution for this. Okay, antithrombin deficiency. This is correct. Correct. Next question, Dr. Asima.
Duration of thromboprophylaxis for after total abdominal hysterectomy for cancer. It is 4 weeks. B.
4 weeks for cancer. So if the patient hysterectomy for myectomy, for example,
then it will be 5 to 7 days.
Hyperplasia.
5 to 7 days.
Yes, anything other than cancer, 5 to 7 days. Cancer will be at least 4 weeks, 28 days. So in the exam, they are putting 28 days. I know it's 4 weeks. Sometimes, believe me, in the exam, mental block will happen. You know that it's 28. He give you 4 weeks, so it's the same. Okay. Okay, we'll start with some hard question. It could be hard. Okay.
G3, 8 weeks with previous history of DVT in previous pregnancy at 30 weeks. So here she is G3, that is score 1. Previous history of DVT, that is score 4 at 30 weeks. So we will give her, she is now 8 weeks. We'll start with the low molecular weight heparin, and as soon as possible, and 6 weeks post delivery.
So which one?
So it should be, I think two are same. Two options are same. C and E.
Which one is the same? C
Okay,
and E is the
that,
same?
C. No, no,
C and E not same.
no, C.
C. So you choose C. I just have request, please. If someone is using two device, please, and just use one device, because now the meeting is 250 and there is much want to enter. So please, if you use two account, just close one and keep one. And the record and PDF I will post. So don't worry regarding the recording. I will post the record. But just to give others a chance to join the meeting, please. Okay, so you choose C. So you start to prophylactic. If he give you any history of thrombosis without giving you the reason, so you are going to give this patient all her pregnancy and 6 weeks a prophylactic dose, because he didn't put what is the reason. Still, we don't know. This patient will need initially prophylactic dose, except the specific reason of the thrombosis, and he is putting a specific reason. We will know how to solve this question. Okay, correct answer.
G3P2, 8 weeks pregnancy with previous history of DVT in previous pregnancy at 30 weeks with antithrombin 3 deficiency, who will often be on long-term oral anticoagulation. Start low molecular weight heparin. So she is a patient with previous DVT and thrombophilia, history of thrombophilia. So and para 3 also. So it will be again start prophylactic dose, but with antithrombin. So we'll go with the higher dose, E.
E. So E, start high prophylactic dose, low molecular weight heparin with hematology as soon as possible and 6 weeks postpartum. Because he gave here high risk patient with high risk thrombosis and antithrombin. So we are not giving a therapeutic dose. Again, we are giving because in the exams there will be option therapeutic dose, and some you will choose. You will choose therapeutic dose if the patient already she has thrombosis now, either DVT or in pulmonary embolism. But if the patient high risk, very high risk to have thrombosis like this patient, you will give her high prophylactic dose. How I will calculate the high prophylactic dose? I will check how much therapeutic dose for this patient, and I will now the patient don't look to any other score. If the patient she has DVT in previous pregnancy and antithrombin deficiency, you need to calculate the score. Already this patient she will take very high dose. You get the idea? There is some keyword once you see this patient will take. No need to calculate other risk factors, because this patient will need high prophylactic. So what is the value if you calculate other? It will be same answer. You get the idea. Antithrombin deficiency and the previous thrombosis, she will need high dose. How we are going to give the patient to calculate the dose? We'll check how much therapeutic dose, and we will give her 50 or 75% of the therapeutic dose. Okay. Usually this patient will be in oral anticoagulant. So we are shifting the patient during antenatal care to heparin, and we will talk how we are going to change. This is I prepare also today.
So you are seeing a 30-year-old primary gravida at her booking visit. Her sister had DVT in her legs with pregnancy last year and suffered much pain and discomfort. She has heard that pregnancy increases the risk of venous thromboembolism and want you to address her concern. What is the most appropriate action to take? She is a 30-year-old primary gravida and she has a family history of DVT. So heparin low molecular reassure test for thrombophilia.
Test for thrombophilia. Don't be confused between the I think if someone attend with venous thrombosis, we tell if the patient she has thrombosis now, no need to test for thrombophilia because this is will not change the management. Thrombophilia later, after the treatment, after 3 months, we can refer the patient to hematology doctor and check if this patient she has thrombophilia or not. But right now, why we are not testing thrombophilia when the patient she already has thrombosis? Because this is will not make the management different. The management will be same. But here, this patient antenatal care, she come in her pregnancy. We don't know if this is her sister. She has thrombosis because of thrombophilia. So this is can change the management. So if something can change the management, so I will test for thrombophilia. So I test for thrombophilia if needed. So in this scenario, this patient pregnant, her sister she has thrombosis. So I need to can change her management. If she is a case of thrombophilia. But if this patient postpartum for any reason or during pregnancy she developed thrombosis herself, don't choose thrombophilia because already she will give her therapeutic dose of the heparin. So what is the value now to do thrombophilia? Sometimes even the thrombophilia can be affected by the pregnancy. So no need to test if the patient develop already thrombosis. This can be done later with the hematology doctor after pregnancy, but you will test if needed, like in this scenario, because it can make the management different. Be careful from the next questions. Next question.
She's a gravida 3 para 2, 8 weeks pregnant with previous history of DVT in previous pregnancy at 30 weeks with antiphospholipid syndrome on long-term oral anticoagulant. So she has a history of antiphospholipid syndrome with thromboembolism with the previous history of DVT. Okay. That is a high risk factor. Yes. So and she's gravida 3 also. So that will give her score 4.
So choose what?
So we will give her, start with the prophylactic dose of low molecular weight heparin as soon as possible and 6 weeks postnatal.
So which one?
Should be C.
C. So you choose C. This patient, she is high, also the same. I will show you something. You will don't be worried. In the end, I will give you the conclusion. Don't worry. I will give you the conclusion. Patient with previous venous thromboembolism and she has antiphospholipid, deal with her same as the patient with antithrombin deficiency. You answer as the same question before. Also, this patient, she will need high prophylactic dose. How I will calculate the high prophylactic dose, therapeutic dose, I will give 50 or 75%. So it's easy, the same answer of the same question of antithrombin deficiency. Okay?
Yes. She is a gravida 3 para 2, 8 weeks with homozygous factor 5. Start with the low molecular weight. Start with 24 weeks. No. Homozygous factor is a high risk, so we will give her start low molecular weight heparin at 28 weeks.
So which one?
1 second. She's a gravida 3 also. No, we will give her E. Start higher prophylactic dose of low molecular weight in collaboration with hematologist.
No, it will be C. It will be C. I will tell you, don't worry. Don't worry. Factor V, homogeneous factor V leading. This is will be risk, high risk for the not very high. It will be high risk. This patient will take only prophylactic. And I will tell you in the conclusion how to not be confused in the exam, because in the exam I will be confused. What I will do in the exam, if we give you patient with history of previous venous thromboembolism and she is taking anticoagulant, it's easy. Patient with previous venous thromboembolism and she is taking oral. This is patient very high or high? Very high, correct? Because she is already taking oral anticoagulant. So this patient, she will take high prophylactic dose and 6 weeks after delivery. Easy, easy until she return back to her. Because I want to just mute. Just mute yourself. I will mute your sound, Dr. Asima. Yes, to make it clear. Be careful. This is the most important table in the guideline. This is the most, and you can solve any questions mostly from this schedule, from this table. Not all the patients you will have thrombosis, they have thrombophilia. Maybe 50% only. So there is one patient, she can have thrombosis and she don't have thrombophilia, but for any reason she is taking this oral anticoagulant. So this patient, she is taking oral anticoagulant. So this patient, she will need high dose, low molecular weight because she is already in oral. So you need to stop the oral and shift her to low molecular weight heparin. And again, after delivery, we will know when we will start again the oral anticoagulant. This is the first patient. He gave you another patient with antithrombin deficiency. This is very high risk patient. Patient with antiphospholipid syndrome with what point with in your mind, not only antiphospholipid syndrome. Some they are thinking antiphospholipid syndrome they will put no. Antiphospholipid syndrome with previous venous thromboembolism. This is the same, similar to antithrombin deficiency alone. So this patient, she will be managed the same, will be need high dose therapeutic dose of the high dose prophylactic dose of low molecular weight heparin during pregnancy and 6 weeks postpartum. So again, how I will give the patient no voice how? No voice? There is voice. I think voice clear. Voice clear? So again, if you have one patient in the exam, how I will choose high prophylactic dose in 3 conditions? It's easy. One patient antithrombin deficiency. So I finish this point. One patient antiphospholipid syndrome with previous venous thromboembolism. One patient with previous venous thromboembolism in oral anticoagulant. So it's 3 patients, 3 cases. It's easy. It's easy and clear. Okay, another patient, she has any venous thromboembolism except major surgery. This is patient, she don't have when they test this patient for any reason, they don't find any thrombophilia, just she developed venous thromboembolism. So this patient, she will need prophylactic dose during pregnancy and 6 weeks. Okay. The point here, and no need for hematology. Why no need for hematology? Because already this patient, usually if they don't have any thrombophilia, so they test her, they don't have any thrombophilia. So if she developed previous venous thrombolism except for major surgery, because major surgery have another, how we are going to give the major surgery, if she developed thrombosis during the surgery, we'll tell how we are going to give her heparin. If the patient, usually giving you the patient, she has factor V leading homogeneous one, she will take prophylactic dose during pregnancy and 6 weeks. Also, there will be hematology because this patient, she has also thrombophilia. So any thrombophilia, hematology will be involved in the management. If they giving you one patient, she has thrombosis because of major surgery, like fracture femur, accident, she developed after accident. So there is reason she developed the thrombosis because there is no thrombophilia, but there is something happened to her, fracture clavicles, any other surgery for her, she developed. This patient, if you look here, down, recommend, yes, it's here considered during antenatal. No, in the exam he will tell you what is the recommendation. The recommendation should be from 28 weeks and 6 weeks after delivery. This is very important. This table is very vital and very easy. If you understand it well, you can answer any question there easily. If he give you something like heterogeneous factor V Leiden, antiphospholipid antibodies, this is all score 1, score 1, score 1. So if this patient, you need to check other scores. Like I find that this patient, she has heterogeneous factor V Leiden, but there is a score another one, like age, so it's 2. So after delivery, I will give her 10 days. So it's only you will deal with her as a score 1. But if he give you something significant risk factor, like he tell you, this is she has a heterogeneous factor V Leiden, but her mother, she has thrombosis. So it's a strong family history. So this patient, she will take 6 weeks. This will be a question in the exam and you can't solve. He put you will tell heterogeneous disease factor V Leiden, it's only 1, but he put something strong that she can have also thrombosis, like her mother or first relatives for her, he develops thrombosis. So this patient, she will take 6 weeks. Even she didn't receive during her pregnancy, she will take 6 weeks. This is, you see, this is patient, maybe she didn't receive during her pregnancy, but maybe this is one of the example of the patient, she can take 6 weeks. It's not difficult. It's not difficult. This is just rules. And usually the questions in the exam will come from this table if you understand it well. Don't worry, we will practice again some questions from the same table. Continue. Doctora, who is me before? Doctora Asima. Doctora Asima.
She's a gravida 6 para 1 plus 4 with a history of recurrent miscarriages, and investigation shows antiphospholipid syndrome, confirmed by 2 results 12 weeks apart. Now she is pregnant 8 weeks with no history of DVT in the previous pregnancy. You want to start aspirin and low molecular weight heparin, but you are not sure about dose and duration of low molecular weight heparin. Gravida 6 gives her score 1.
Gravida 6 score 1. Gravida 6 score 1.
And with a history of APLA, antiphospholipid syndrome, score 1, because she is not having any previous history of venous thromboembolism.
Okay.
And recurrent miscarriages.
Difficult question.
That is
if you answer this, $100. Okay.
So
but
it
no
should
one
be.
But if this can
if
be for the $100, no. Only Doctora Asima. Okay. Don't give her the answer also in the private. Okay.
7 and 3 to 1 second. No, so she's having a score of 2 only here.
2 only. Okay.
Yeah. No, what I'm thinking is that should we start here, because they are asking about aspirin and low molecular weight heparin because of antiphospholipid syndrome, then we should start it as soon as possible.
Why you will give her heparin in this condition?
Because of the recurrent miscarriages.
Yes, recurrent miscarriage. Correct, correct. So I started to understand the question. Yes. So
start the low prophylactic dose of low molecular weight heparin as soon as possible, and then postnatally should be 6 weeks or 3 to 5 days. Postnatal, we have to calculate the risk again. So again, the postnatal risk will be 2 only. So it should be 10 days, 3 to 5 days post delivery. D.
You will calculate the risk of delivery after delivery.
After delivery, we will calculate again.
Okay, so answer.
There's no voice.
Yes, I'm with you. I'm with you.
So should we take it as or D? Because if we calculate the risk postnatally, it will be 2
Okay,
only.
so leave the risk. This
Otherwise,
patient
we
for
otherwise
recurrent
it is C.
miscarriage.
Otherwise, it
For
is C.
recurrent
For
miscarriage.
yeah, recurrent
For
miscarriage,
recurrent
it is C.
miscarriage.
C.
B. B.
No, C. C. Start prophylactic low molecular weight heparin as soon as possible and 6 weeks post delivery.
In the exam, which one you will choose?
I think I will go with the C because they are asking for the recurrent miscarriages. I will go with C.
Okay. At least I save $100. Okay. The point here, I will tell you, the question here, tricky question. Tricky why? Because this patient, first of all, gravida 6 is score 0 because the patient is bara 1. The score bara 3 or more. Be careful. I like that you answer it wrong. You know, I like that you answer it wrong. Why? Because gravida 6, he didn't give you gravity in the score. He put you parity. He bought bara. He didn't
Yes,
put correct. So gravida even 20, he didn't put. He tell you bara 3. So bara 1 here, it will be 0. Correct. So it was an excellent idea that you put it in wrong way. So we'll learn something new. This patient recurrent miscarriage. And when they investigate, and they are putting antiphospholipid syndrome 2 result to confirm it. So this patient, I need to give her for her baby now, because according to the score, no need for low molecular weight heparin as thromboprophylaxis. But I need to give her for antiphospholipid syndrome, correct or no?
Yes.
So for the recurrent miscarriage. So the idea here, I will give low molecular weight heparin during the pregnancy and aspirin. And they will stop the heparin when, Dr. Asima, in the patient recurrent miscarriage, she is taking heparin. When they will stop?
At the time of delivery?
At 35 weeks, stopped between 35 weeks and the delivery. In the patient's thromboprophylaxis, no. She is taking until the time of delivery and will instruct her. If emergency, she will stop injecting herself if she started to have labor pain, or elective will instruct her to stop 12 hours before coming to the hospital, the last dose. So in the antiphospholipid, we are giving for the baby because this patient has recurrent miscarriage. So we can give through her pregnancy, and she will stop at 35, between 35 and the delivery. But after delivery, this patient, sure, you will assess the risk of thrombosis again. But according to the scenario given, any patient take for her baby because of antiphospholipid syndrome only, some they are thinking, if I will give the patient in whole the pregnancy, I will give her also 6 weeks. No, in this scenario, you are giving for the baby only, not giving as a thromboprophylaxis. So some thinking in the exam, I will give her all pregnancy and 6 weeks. Wrong. You will give her according to the guideline in whole her pregnancy. You will stop between 35 and delivery. And again, you will give her postpartum 3 to 5 days only as she received for her baby, except if there is any other risk factors appear. It's very tricky questions. It's very tricky questions, and be careful before you answering any question in the exam. Sometimes in the exam, he will give you just 1 minute. Be careful. He can give you a scenario about recurrent miscarriage, and he will tell you antiphospholipid antibodies done, it's positive, and you will run. I know what this is what happened, and we will choose low molecular weight heparin and aspirin, and this will be a wrong answer. Why? Because he gave you only one result. To confirm, you need again to give her. You will start from the start of the pregnancy. We will start in the recurrent miscarriage from there is different sources, some from the fetal heart, but no, you can start from the start of the pregnancy for the patient low molecular weight heparin, but the point after delivery, how much you are given, only 3 to 5 days if no any other risk factors. Regarding recurrent miscarriage, if antiphospholipid antibodies positive, Be careful. You can't confirm until you repeat again after 12 weeks. So if the answer there is repeat again, you need to repeat. So you have 2 consecutive result, positive 12 weeks apart. I wish you remember in the exam. Okay, so this is the antiphospholipid antibodies. Patients, you should have one loop anticoagulant positive, anticardiolipin positive, B-glycoprotein 1 antibodies positive. Any one of these, just if it is positive, I need again to repeat it after 12 weeks. Okay, next. 3 to 5 days, you can't find in the guideline. No, it's there. It's there. You can't find really? No, it's there. Okay. I will copy paste it. Okay, I will copy paste it after the session and I will put. Okay.
Para 1, history of previous 1 normal vaginal delivery, no history of DVT. Antiphospholipid antibodies confirmed by 2 results, 12 weeks apart. Now she is pregnant, 8 weeks. You are not sure about the dose and duration of the low molecular weight heparin. So she has a antiphospholipid antibody syndrome positive with no previous history of no DVT, and she is para 1 only. So we'll start.
I know that you are suffering with me today. Asim, I know. You are not lucky because we are taking on the... Okay, no problem.
So we'll start with the low molecular weight heparin as soon as possible because she has a positive antiphospholipid antibodies. And
how much percentage of the patients you will have antiphospholipid antibodies without any symptoms?
15%.
2%. In the guideline, it's 2%. So this patient, we tell just now, we tell in the table, if you remember the table, what we tell in the table, we tell if the patient, she has antiphospholipid antibodies with thrombosis, this will be high risk patient. If antiphospholipid alone, this will be score 1. So no need. She don't have any, no need. This is antibodies. Patient don't have any problem. We tell before, if the patient in the end of the table down, if you remember the table, in the end, they are putting the some only risk factors like heterogeneous factor V leading. Antiphospholipid antibodies without any symptoms, she don't have any recurrent miscarriage, she don't have any problems, so no need. She don't have any symptoms. There is about 2%. I don't put here in the there is 2% as I remember. It's 2% only. It's 2% only of the patient they can have antiphospholipid antibodies without any problem. So this patient, why you are giving it to her? She don't have any recurrent miscarriage. She deliver her baby normally. She don't have any problem. Any history of thrombosis? No, she don't have. So patient can have antiphospholipid antibodies without any symptoms in 2%. And how much is the score? In this case, it will be only 1. So 1 mean what? Mean I will, if there is additional, I will calculate 1 plus the age according to what is given to me. But antiphospholipid antibodies alone without any problem, this is not, it will be only score 1. So we have today different scenarios about antiphospholipid antibodies. Again. You make us confused. No, this is just rules. This is the easiest way to put rules for in the guideline for thromboprophylaxis. Now I have antiphospholipid antibodies confirmed by 2 results 12. Someone tell why we are doing for her. Okay, by luck, for any reason, antiphospholipid done for the patient. She don't have any complaint, any history of thrombosis, no. Any recurrent miscarriage, no. It's happened in 2% asymptomatic, nothing. So it will be score 1. 1 patient for recurrent miscarriage. So we are giving her through her pregnancy for her baby. After delivery, and we will continue until 35. We can stop from 35 or between 35 and delivery, and we will start again 3 to 5 days after delivery. Patient with antiphospholipid antibodies with thrombosis, previous thrombosis. This is very high risk for thrombosis. So I will give her high prophylactic dose during her pregnancy and 6 weeks with the hematology also involved in her management. How I will calculate the high prophylactic dose? 50 to 75% of the therapeutic dose. Easy? Easy, yes, easy. Easy. How I will tell that this patient she has a problem in recurrent miscarriage? If confirmed antiphospholipid antibodies in 2 reading 12 weeks apart, and she has 1 clinical symptom. So I need to tell that this patient she has antiphospholipid syndrome. Either she has 1 baby died after 10 weeks, morphologically normal, not baby with congenital anomalies. After 10 weeks, he died because he has congenital anomalies. So if 1 or more morphologically die after 10 weeks, if she has 3 consecutive 3, not because some patients she will tell you, I have 1 baby, then I have miscarriage. I have another 1 baby, then I have miscarriage. This is not recurrent miscarriage. If she has 3 or more consecutive miscarriage before 10 weeks, or she has 1 baby preterm before 34 weeks because placental disease. 15% of the patient of recurrent miscarriage, you will have antiphospholipid antibodies. And if you will not give her any treatment, the live birth only will reach to 10%. If you listen for the session for the first time, it will be difficult. But I believe if you again listen it carefully, you will know the idea from the questions and it will be more easy. But if you go and read the guideline, really the guideline is very long, and maybe you will lost even, and you can lose very important information in the guideline. Okay, Doctora, again, Doctora Asima?
Yeah. She is a gravida 3, para 2, 8 weeks with the previous history of DVT after major surgery at 30 weeks. So here para will be 0. Previous history of DVT is there, and that is after major surgery. So it will be intermediate risk, very high intermediate risk, I think. So
what is the recommendation? What is the recommendation?
Not a low molecular weight, 28 weeks.
Yes. So what is the answer? It will be.
So it will be D.
D. So if patient with major, just fix the rules. It's rules easy. When he put in the scenario the patient she has DVT because of surgery, so it's easy. What is the recommendation? So from 28 weeks to 6 weeks postpartum, it's easy. If you put certain rules and you repeat it again and again, it will be easy. Thank you, Dr. Asima, for sharing. We can. No, she has major surgery at 30. Sorry. She has major surgery. Sorry. In the previous in major, she has DVT after major surgery. Sorry, it's related to the surgery. Maybe she is pregnant. No problem. No problem. But in the exam, don't worry. He wanted to give you. I know that you are confused regarding that. Maybe it's related to the pregnancy. But in the exam, don't worry. He can usually in the exam he will give you that this patient I just will remove 30 weeks. He will remove to make it more better, easier, because in the exam he will put you clearly that this patient she has thrombosis because of the fractures. Okay, so don't worry at all regarding this point. Okay, so I think Doctora Nikhat. No problem. I remove the 30. Not make you confused regarding that she is related to the pregnancy. So don't worry in the exam. So I again the schedule again. This table is very important. Patient I now know. I am very clever. Very high risk patient. Patient if she is previous venous thrombosis and she is taking anticoagulant, antithrombin deficiency alone is enough to giving her high prophylactic dose. Antiphospholipid syndrome with venous thromboembolism, you will give her high prophylactic dose during her pregnancy and 6 weeks with the hematology involvement. If he give you thrombosis not related to major surgery, we tell 50% only of the patient to develop thrombosis because of thrombophilia. So if one patient from the other 50 develops thrombosis, this patient she will take during the pregnancy prophylactic dose and 6 weeks. No need to involve with the hematology because she don't have thrombophilia. Patient with homogeneous factor V, she will take antenatal care, prophylactic dose, and 6 weeks post-delivery, and also involve with the hematology. Patient post-fracture, thrombosis, she will take from 28 weeks and 6 weeks postpartum. Patient with heterogeneous factor V leading, if other, it will be score 1. If she has any other risk factor score 1, you will give her 10 days. If there is a strong family, he will give you a patient heterogeneous factor V leading, and her mother, she has thrombosis, you will give her 6 weeks. I think the question will come from this table. This is what I believe. We can take another candidate, Dr. Nikhat. Dr. Nikhat, I think Dr. Nikhat, the one writing on the chat, who someone telling I am for September. Dr. Nikhat or who?
Yes,
Anyone
ma'am.
for September?
I'm Nikhat.
Dr. Nikhat?
Yes, ma'am. Yes, ma'am.
What?
Women, shall I read?
What is? Yes.
I'm Dr. Nikhat, ma'am. Shall I read? Women on long-term
Yes, Dr.
warfarin or
Nikhat.
other oral anticoagulant should be counseled. Warfarin should change to low molecular weight heparin, ideally within how much period from missed period? 3 days, 2 weeks, can continue on warfarin, should stop gradually over 4 weeks. Can women on long-term warfarin it's not 2 weeks, ma'am.
2 weeks. Why
On
we are
long-term
changing to molecular weight heparin? Why we changing?
long other oral addition.
Yes, it causes
In
congenital anomalies
pregnancy,
to the baby.
uh,
Yes, it's cause. Correct.
2
Ideally,
weeks.
correct. Your answer correct. Ideally, stopped within 2 weeks. Should be from
Because
2
of
weeks to
warfarin
6 weeks. Because
embryopathy.
if the patient use 6 weeks to 12 weeks, this baby, he will have multiple congenital anomalies, include saddle nose, as in the picture, congenital heart defect, ventriculomegaly, genesis of corpus callosum. If the patient is taking warfarin and she asks you, doctor, how much chance my baby will carry this congenital anomalies? It's only 5%. So 5% of the patient, of the fetus, of the mother taking warfarin between 6 weeks and 12 weeks, they will have this congenital anomalies. But 95% they will not have. Just to imagine, don't think that all the patients, but we will stop. Okay. So your answer correct. So ideally stop within 2 weeks. It's better to stop before 6 weeks. So from 6 weeks to 12 weeks, there is high chance for warfarin embolism. Where are you?
Warfarin crosses the placenta. Warfarin crosses the placenta, leading to an increased risk of congenital anomalies, including warfarin embryopathy. There is evidence that this incidence is dose dependent, with a higher incidence in women taking greater than 5 milligram per day.
So you choose 5 milligram B?
B.
Yes, it's dose related.
5.
They tell the risk will be more. Yes, it's correct. The risk will be more if the patient taking 5 milligrams. So if the patient taking 2 milligram, you will tell her the risk will be low, but still there. But the risk will be higher for the patient greater than. This is very important. Sometimes even in the OSCE exam, he can give you patient with 2 milligram and she will ask you, this is risk. The risk will be higher if you are using 5 milligram, but if you are using 2 milligram, still there is risk also. Okay.
Women on long-term warfarin should be counseled. Warfarin should change to low molecular weight heparin, ideally within how much period from missed period, with a history of mechanical valve heart. Same 2 weeks, ma'am, because first
2 weeks.
First time
2 weeks.
we have to
No,
continue. We have to continue
warfarin.
warfarin, but the first time. Okay.
Yes. No, you will continue in this condition. There is some condition will be risky for the patient to stop warfarin. This will include mechanical heart valve. They will bring like this patient with mechanical heart valve. If you know the information, no, I will stop the warfarin. It should be stopped within 2 weeks. This is will cause sudden nose congenital. No, but in case of mechanical heart valve, it's a safer option for the patient to continue on warfarin. If you change warfarin to monomolecular, because some asking in the chat, If you are changing the warfarin to low molecular weight heparin, you will continue low molecular weight heparin until the end. And we will mention when we will stop the heparin after delivery. But we don't want to answer the next questions. Okay? Continue, Dr. Nikhat.
Full first trimester will continue, ma'am. Full first trimester with warfarin.
Yes, all.
Full.
Once, yes, mechanical heart, she will take in all her pregnancy.
Fully.
You will counsel her about the rest.
Okay.
Tell her I can't change to low molecular weight heparin because she is on mechanical, because the risk of thrombosis will be higher. So this patient should be continue in warfarin. This is very important information. Mechanical heart, all, you will continue in warfarin.
Okay. Patient post-vaginal delivery, she was on warfarin before pregnancy, which was changed to low molecular weight heparin during pregnancy. She asked you when she can start again warfarin. Warfarin should be delayed for at least 5 days.
Why?
For risk of bleeding.
Yes, yes. She tell you, doctor, some patients she will tell I don't like injection, especially if she taking the injection much time. She will tell you, doctor, please, if you can change for me oral. So you will tell her we can change oral, but at least we need to postpone at least 5 to 7 days postpartum to minimize the risk of hemorrhage. But it's not logic if you are giving one patient 10 days, not logic. You are giving one patient 10 days and you are going, because you will return the patient to warfarin. Why? Because she is already taking before. This patient usually she is taking warfarin before delivery. So you need to return her to her treatment. You get the idea? So if I wanted to get some patient, I will change it to low molecular weight during pregnancy, except the patient like for mechanical heart disease. She will continue. So no problem about this patient. The patient she changed. She wanted to return the treatment after finish. You will change for her because you will worried about her baby, and she continue on low molecular weight heparin. So after delivery, she tell you I wanted to return to my drugs. So at least 5 to 7 days. Okay. But if the patient taking only for any reason 10 days and she tell you I don't like injection, but she will take only 10 days and she will not even need it for warfarin. So no need, just you will continue on the low molecular weight 10 days until her continue 10 days because she will not need warfarin for longer time. You get the idea from this? So if the patient will return, it should be for longer time, like she is taking 6 weeks. She don't want to inject herself in 6 weeks. So no problem, we can change for you. But 10 days, not logic. So 10 days, she can continue on the low molecular weight heparin. And also it's safe, either low molecular weight heparin or warfarin, both safe in breastfeeding. Monitor of anti-XA level, it's not routine for the, not required for the patient low molecular weight heparin who are taking thromboprophylaxis, and the dose of low molecular weight heparin should be reduced with patient with renal impairment. Only platelets count to monitor for patient with unfractionated heparin. This is just some information. Okay, next. Next, doctor, where are you? Dr. Nikhat. Dr. Nikhat.
Oh, sorry, mic is off. Okay, ma'am. Para 3, post-cesarean section, her weight 90 kg at booking visit. You want to prescribe her low molecular weight heparin, dalteparin. 90 is 7,500, ma'am. I'm not, don't remember. 7,500.
5,000. Why?
Yeah. Oh,
because
90. Oh, okay. 91. Okay.
Just by pen. I have a small paper and pen. Enoxaparin, this is the Clexane you are using. Usually you are using Clexane. So 20, 40, 60, 80. So it's easy. Just you put it in paper. 250 dalteparin, 5,000. I'm increasing 2,500. 7,500. So it's easy. I will make it 50, less than 50, 50 to 90. From 91, this will be another thing. So 90, it will be the end of that. So it will be 5,000. I got this because I know that you will choose 7,000. I know that you will choose. Why? Because you are putting 90 in everywhere. No, 90, it's 50 to 90. So it will be 5.
I thought more than 90s.
Yes, no problem. I just to learn to be careful regarding the numbers. No problem. You can use the booking also weight. He can use unfractionated heparin. If he give you the patient in bleeding now, she is bleed now, she has hematoma, she has intra-abdominal hemorrhage, you will stop heparin. Any heparin you will stop. But if he give you patient suspected mean I'm still suspecting, I didn't take this, I still not take decision for the patient, still I will think. So if he give you something suspected, you will use unfractionated heparin, because this will be short time and it will be short half-life, and even you can use if your patient suspected heparin, you will stop and you can transfer the patient to the operation. So it's better to avoid low molecular weight heparin in patient suspected hemorrhage. So if he give you patient in hemorrhage, hematoma, abdominal hemorrhage, stop. If he give you, I want patient risky for thrombosis, but you suspect, but you want to give her, but you will shift her to the operation now. No, but just I am suspecting, but still I am not taking a decision. But still the patient will be in the hospital. You need to give her thromboprophylaxis, so you can use unfractionated if you suspect the patient has hemorrhage. No dose heparin not used as a thromboprophylaxis. Some doctors thinking that is aspirin. No, this is not thromboprophylaxis. Okay, next.
Postnatal thromboprophylaxis for patient known heterozygosity for factor V laden. Her mother had pregnancy related VTE considered for
Postnatal thromboprophylaxis for one patient heterogeneous.
Okay.
Tell the factor V heterogeneous how much is the score? Factor heterogeneous factor. Just we tell in the end of the table down. We tell factor V latent heterogeneous will be score 1, and if there is additional 1 risk factor, we will give for 10 days. And if the patient, but if the patient she has strong family history of thrombosis, and here her mother, we will give for how much? End of the table down. Just now I put
10 days.
No problem. I just will revise it again. Factor V latent heterogeneous type. It's only score 1. If there is additional score postpartum, I need to give the patient 10 days. But if there is a strong family history of thrombosis, I will give her for 6 weeks. You see, Dr. Nekhat, you see this one?
Yes, ma'am.
Or 6 weeks. If significant family history, 6 weeks. So heterogeneous type will take either 10 days, 10 days. If she has another risk factor, so it will be 2. So I will give 10 days because 2, 1 and another 1. But if strong family history, I will give her 6 weeks. This is very important because it will be difficult in the exam. How heterogeneous 1 and strong family. It's written clearly in the guideline. Give him 6 weeks. He tell you in the guideline. Okay?
Yes, ma'am.
Easy or not?
Yes.
Not easy. Not easy at all.
I thought 1 plus 1 2.
No, it will be easy if you repeat. If you repeat, believe me, if you repeat, it will be very easy. Just repeat. Okay.
Pregnant women, she's for cesarean tomorrow. She on prophylactic dose of low molecular weight heparin, asked when she stopped before the operation. 12 hours.
12 hours. Excellent. So if she is taking a therapeutic dose,
24 hours for therapeutic dose.
So 12 hours. Yes, 12 hours for prophylactic dose. Therapeutic dose need at least 24 hours to stop before the procedure. Excellent. Easy question. Okay, next.
Patient post-vaginal with epidural analgesia, epidural catheter removed now. The nurse asked you when should she give low molecular weight heparin? After 4 hours.
After 4 hours. To make it easy for you, because sometimes we are confusing in the exam. If the epidural catheter removed, you remove already. So it's the same the spinal, because the spinal there is no any catheter, and if you remove the epidural there is no catheter. Correct or no? Correct or no? So if you remove the epidural, there is no catheter now, and the spinal there is no catheter now because they are not putting catheter in the spinal. Correct? So in both condition, we will give after 4 hours. Easy? Easy?
Yes, ma'am.
Not
Yes, ma'am.
easy.
4 hours. Easy, ma'am.
Okay. I can't believe. Okay.
Patient patient post vaginal delivery in epidural, low molecular weight heparin given now. When should the epidural catheter removed after? 12 hours, ma'am?
Yes, 12 hours. How I will remember
12
in the
hours.
exam. Sometimes in the exam, the mental block and the confusion. Remember, if I inject this patient heparin, I am imagining. You remember my session. I just injecting the patient. If I will remove the catheter from the patient back, there will be a space. Correct? If I'm removing the catheter, there will be space inside. So this space will be risky for the patient. So it's better to prolong the removal. So how much it will be 12 hours? Easy or no? Easy. So I will remember now, if I'm injecting the patient heparin, I will remove the catheter when. Remember, if I am removing the catheter, I will leave a space inside. So if this space will be there, the risk of hematoma will be larger, more. So it's supposed to be 12 hours. So again, if the patient remove spinal, if patient post spinal or catheter removed already epidural, I will give her after 4 hours. Easy. If the patient catheter is there, she tell you I want to epidural for any reason. She tell you I want to continue epidural for 1 day. No problem. This is her right. So if the patient receiving heparin, the nurse asks you when the epidural should be removed. So 12 hours from the last injection. Because remember, if you're removing the catheter, there will be a space, and this is increase the risk of hematoma. Should be delay more, so it should be 12 hours from the recent infection. Okay, next.
Yes, patient post cesarean section, you suspect intra-abdominal hemorrhage, but you want to start thromboprophylaxis as no plan to reopen the patient right now. Unfractionated heparin.
Yes, I just answered. Suspect. No plan to open the patient, so you can give unfractionated heparin. Thank you a lot, Dr. Ikhat, for sharing. Thanks a lot. We can take another candidates. One from September exam. Thanks a lot. Anyone from September exam? For September exam, please. Anyone from September? No mail. There is no any mail will sit in September exam. No one mail only. Okay, this is the contraindication of low molecular weight heparin. You can just have idea regarding active bleeding, like patient active bleeding, patient at risk of major hemorrhage like placenta previa, patient with severe renal impairment, severe liver impairment. Anyone from September for September exam? Anyone for September exam? This will be very important. Anyone from?
I can answer. I can answer.
What is your name? You chair today, Dr. Nikhat?
Nikita.
You chair today?
Yes, ma'am.
You chair today?
Yeah,
you chair
Nikita.
Today? Nikita, you chair today?
No,
Just
no.
now you finished. No? Okay.
No,
okay,
no,
Dr.
no.
Okay. You can start.
Admission to hospital during pregnancy is associated with increased risk of VT incidence ratio compared with time outside the hospital. 5-folds. B.
Admission to the hospital increase the risk of thromboembolism 18-fold. I answer correct. Okay. And even they mentioned that even after the discharge, the risk remain high. It's about 6-fold high in the first 28 days. This is just for your knowledge in your daily life. If you have one patient in the admission, talk to yourself and tell patient if admitted to the hospital like this. You talk to yourself in the duty. They will think that you are crazy. No problem, but I wanted to pass the exam. Just give me chance to pass. If the patient is admitted to the hospital, there is increased risk for her 18-fold to have venous thromboembolism. And even this risk will remain after the discharge. It will decrease bit than 18, but it will remain about 6-fold, especially in the first 28 days after discharge. Okay, easy question.
The use of properly applied anti-embolism stockings of appropriate size and providing graduated compression is recommended in pregnancy and the puerperium for women who are hospitalized and have a contraindication to low molecular weight heparin with a calf pressure of C, ma'am, 25.
The pressure. 14 to 15.
I'm not sure. Yeah, 14 to 15. Yes.
For the anti-embolism stocking. Okay. Okay, some definition in the guideline regarding long distance. Sometimes the patient, she will tell you it's risky for me to travel. Any travel more than 4 hours, either by the train or aeroplane, it will be risky for thrombosis. It will be like score 1, like you are giving score 1 for this. Admission 3 days or more, this is bed rest post if patient admitted and not mobile. This is especially if 3 days or more. Prolonged labor, it will be more than 24 hours. This is another risk factors for thrombosis. Antepartum during like patient at home, not admitted. If she is take rest for 1 week, and the problem there is some instructed the patient, I don't know, some even instructed the patient to take rest, especially if she has bleeding. Rest is very increased risk of thrombosis for the patient, so be careful. Be careful. So rest 1 week or more in bed for the patient. Anything, car, train, it's written in the guideline, it is not exclusively by air. So it can be anything you travel, either car, train. So it's not exclusively by air. So this is the first definition. Admission, if patient is 3 days, if you have one patient and you are not planning to discharge here, review again the risk assessment at 3 days, especially if you are not willing to discharge the patient. If patient rest at bed during antepartum, before antepartum period, 7 days, this will be high risk to patient to have thrombosis. If patient she has long distance more than 4 hours, this is also need again, because this patient need to check other risk factors for the patient. Prolonged delivery or more than 24 hours. Okay.
Ghazala, please mute your mic. Please mute your mic.
Which doctor? Dr. Ghazala. I will mute her mic just a minute. But the problem, if you are closing every time, it will take much time to mute. I will mute all now. Okay. Just I will touch a very important topic. There is some patient will come to you in the clinic. She is taking oral anticoagulant for any reason. Like she is taking warfarin, she is taking Roverexban, and you are planning for this patient to do for her like hysterectomy or other procedure, gynecology procedure. This is very important topic. I think there is one TOG articles, recent TOG articles 2020 March. And this is really very vital. And I expect that this is could appear in the next, not exam, not maybe September, maybe the next exams next years, because this is very important topic. And even in part 3, you can face a task about thromboprophylaxis, bridging. What is bridging? What is the idea from bridging? The idea from bridging is that you have one patient like she is in oral heparin. This is patient, just this is example to understand the idea. Like you have patient in oral anticoagulant here, and you are planning to do hysterectomy. This will be risky for her, risky for bleeding and risky for thrombosis as an operation. So how you are passing this difficult time for this patient until you return the patient again to her oral anticoagulant. This is the bridging, the idea from the bridging, especially if the patient at high risk of thrombosis. If low risk of thrombosis, no need for bridging. Bridging done only for patient with high risk of thrombosis. You should know the word bridging. What is bridging? Because this can appear in single best answer or can appear in AMQ. The idea we want to give the patient low molecular weight heparin in spite of oral anticoagulant. During the time of operation, we will know when to start and when to stop. And this can be also a task in part 3. Be careful. And can be a question in part 2. Assessment of the patient for the risk of thrombosis. If I have one patient at high risk of thrombosis, why she is at high risk of thrombosis? Because she is taking oral anticoagulant. She is at risk, and also you are going to do surgery for her. Admission, so this is risk for operation, and also she at risk of bleeding because of the surgery and because of the treatment she is taking. So you need to do balance between the risk of bleeding and risk of thrombosis. So assessment of this patient is very vital. Assessment needed at least 7 days, and the idea we need to change the patient at high risk only, not low risk for thrombosis. High risk of thrombosis, will do bridging. We'll change the oral anticoagulant for her to low molecular weight heparin, and this is called bridging. We are giving the patient, in spite of long-acting anticoagulant, we are giving her heparin short-acting. Bridging. Don't forget this word. I know it could be difficult. These questions could be difficult, but still you can answer. Well, Dr. Nikhat, Doctor, what is your name again? Who's Dr. Nikhat?
Nikita, ma'am, yeah.
Nikita, sorry. Nikita.
Warfarin are best discontinued before gynecological procedure.
Yes, you are patient with warfarin and you are going to do hysterectomy for her. She asked you, doctor, so when I will stop?
I think 7 days.
5 days. So here's the patient again. We need to give her 5 days heparin. If the patient at high risk of thrombosis, you can do bridging, you can stop the heparin, and you can start for the patient low molecular weight heparin in the preoperative period during the 5 days. But be careful that we need to stop at least 24 hours because usually they are giving them high prophylactic dose. After this again, after the delivery, we will start again prophylactic dose. Especially you are giving prophylactic or high prophylactic. If the patient at high risk of bleeding, just start prophylactic dose. You get the idea? Until the patient no more risk for the bleeding, you can increase the dose to high prophylactic dose. After this, after 2 days of the operation, you are giving low molecular weight heparin. In the 3rd day, you can start again, at least 48 hours, you can start again warfarin. So I do bridging now. I stop before 5 days before the surgery. I start again after 2 days. So during this time, what I use heparin. When I stop the heparin, 24 hours before the procedure. When I can start, you can start 4 to 6 hours if there is no any more risk of bleeding for the patient. This is bridging. So if you have Dr. Nikita, if you have one patient, she is on warfarin, but you can't wait for 5 days. She come today for emergency procedure, whatever the procedure. What you will do?
Bridging with the last dose given 24 hours pre-op.
No, it's better if she come in emergency to wait for 8 hours. If possible, you can wait for 8 hours. It's possible. And you can give her 5 milligram phytomenadiol. You can give her this treatment 5 milligram, and if you can't wait at all, you can give higher dose of the same treatment. This one, phytomenadiol. This is antidote for the warfarin if the case emergency. So it's better to wait for 8 hours, and you will give her 5 milligram IV even you wait phytomenadiol. And if you can't wait, you can give her higher dose. It will be about 50 units per kilogram if you can't delay. Rovarexban. So that's the question.
Patient on rivaroxaban, she has antithrombin 3 deficiency and for total abdominal hysterectomy for cancer. BMI 55, creatinine clearance 30 ml per minute. When rivaroxaban should stop before operation?
Rivaroxaban.
I don't know, ma'am.
This is very important. Rivaroxaban, warfarin. No need. We are not a hematology doctor, but you can face a question either in part 2 or part 3 about when you should stop. Okay, rivaroxaban. It will be 2 days. 1 minute. Yes, 2 days. How I will know? Rivaroxaban, this is very important drug. Very important drug. Okay? Very important drug again. How I will remember rivaroxaban? If the patient at low risk of bleeding or high risk for the bleeding, I will stop according to the creatinine clearance. If creatinine clearance 30 or more, 1 day. If less than 30, 2 days. So in low bleeding risk, it will be 1 day and 2 days, easy. In the patient high risk, 2 days and 3 days. It's easy. How I will remember it's 1 day or 2 days. If the creatinine clearance got to a 30 or more, I will stop 1 day. If the creatinine clearance less than 30, I will give a stop for 2 days. This patient at high risk. High risk, why? Because she is already, she has antithrombin deficiency, and she is for thrombosis, she is for hysterectomy, high risk for the bleeding. So this patient, I will give creatinine clearance. Creatinine in high risk patient with the bleeding, I have 2 days and 3 days. Creatinine clearance more. Just mute your mic, doctor. If the creatinine clearance more than 30 or more, it will be 48 hours. What is the question will come in the exam? Mostly this one. Mostly this one. Mostly. I don't know. It can be anything. Anything can appear. Okay? Anything can appear in the exam. But my expectation, it will be one patient with high bleeding risk. High bleeding risk, I will look to the creatinine. 30 or more, 2 days. Less than 30, 3 days. It will come this one. Usually it will be this one. Creatinine clearance will be 30. Creatinine clearance 30 and high risk of bleeding 2 days. Easy. This is the most important part in this table. Rivaroxaban, you can also take warfarin. Dr. Nikita?
Yes, ma'am. Aspirin are best discontinued before gynecology procedure. Aspirin. Actually, no need to stop.
No need to stop. Excellent. No need to stop aspirin. Aspirin, this is very short half-life, 15 minutes. Short life, 15 minutes. You can imagine. So it's no need to stop. As a monotherapy, no need to stop before any. If she tell you I taking aspirin, you want to do gynecology procedure, no problem. Do whatever, and she can continue on aspirin.
But if she's on antiplatelet like clopidogrel, then she has to stop for 5 days before. Yes, 7 days. Yes, clopidogrel, 7 days.
Clopidogrel, 7 days. This is very important drug also. Antiplatelets. This is irreversible. His action, its action not reversible, but it's you give times for the platelets again to reform it. This is the lifespan. Why 7 days? This is the lifespan of the platelets again to have platelets, good platelets. If the patient, for example, she come for emergency and she taking these drugs, you can give the patient tranexamic acid, and if the platelets very low, you can give even platelets transfusion. Excellent. Don't forget this number. Okay, clopidogrel.
Yes.
I put only the important drugs which could appear in the exam, and you can need only one question to pass. Okay.
ADP and adenosine diphosphate receptor antagonist are best discontinued before neuraxial anesthesia.
I know it's you are not lucky because you are taking the bridging and the difficult parts in the anticoagulant, okay, and the antiplatelets also. So don't worry if you answer any question. It's difficult, but the idea here that this is very important drugs. When I will stop rivaroxaban, when I will stop warfarin, when I will stop clopidogrel, when I will stop adenosine diphosphate receptor antagonist. Okay, just I will. It's easy. Just need to repeat 2 times. It will be easy.
I don't know, ma'am. I don't know this.
So adenosine diphosphate receptor antagonist. I think this was a question in the CBD. TOG. 7 days. 7 days. This was a question in the TOG of March 2020. 7 days should be stopped. So it's the same to the clopidogrel. Same. We can make it same. It's easy to remember or no?
Yes, yes.
We can. So it can make it. You tell me we can stop clopidogrel 7 days. So we can do also for adenosine
diphosphate
receptor antagonist. Just to remember. Because our memory usually not work in the exam. Next. Dual
patient is taking dual therapy because of recent acute coronary syndrome. What are the best discontinued before gynecology procedure for myomectomy? Today is not my day.
No, because this is recent blog article I mentioned for you. No, it's difficult. Even for me, when I'm preparing, it's difficult. But I have idea regarding rivaroxaban, clopidogrel. I have idea from part 2. But this is because of recent talk. I just put because this is really important. Dual therapy. If the patient is taking the dual therapy, usually if she has they are given before acute coronary syndrome. They are giving them either they will give aspirin and something antiplatelets like clopidogrel, both. So it's better to postpone the operation for 6 months. If not possible, if the patient at low risk of bleeding, just to continue both. If patient at high risk of the bleeding, you just need to continue in the aspirin safely during the procedure. Okay.
Okay.
Again, dual therapy, you are giving two antiplatelets, aspirin and clopidogrel. If the patient she has recent acute coronary syndrome, just we need to postpone the operation 6 months. If there is something, we can wait. If no possibility to wait, something emergency, so we will look this patient at low risk of bleeding, we can continue. If patient at high risk, aspirin, we just mentioned we can use aspirin, okay? And we can continue in the aspirin and stop clopidogrel. This is just an article. Just we need to know some important information, especially if there is questions in the CBD. Okay, next. There is another type of dual therapy using ischemic cerebral vascular. They are using dual therapy for the heart and another dual therapy for cerebral vascular disease. They are giving aspirin and adenosine diphosphate for the patient cerebrovascular disease. Ischemic cerebral vascular disease. This will be dual therapy. So we have different dual therapy. Okay, so the dual therapy in the case of ischemic cerebral vascular disease, this will be aspirin and adenosine diphosphate receptor.
What are best discontinued before gynecology procedure for hysterectomy for cancer? Continue aspirin and stop ADP receptor antagonist. A.
Yes, patient at high risk with aspirin, we can continue. It's easy. You have now dual therapy too, correct? If the patient with coronary problem recently, it's better to postpone for 6 months. If we can't postpone, patient at high risk of bleeding, continue aspirin and stop clopidogrel. If the patient with ischemic cerebral vascular problem, she is taking aspirin and adenosine diphosphate receptors. Patient at high risk of bleeding will continue an aspirin and stop. It's easy, correct or no? Just we need to know the information. If we know the information, it will be easy, correct or no?
Yes, ma'am.
You are not lucky today, but believe me, this is difficult task. Okay, last question. I prepared today, actually, I will tell you, I prepared today only 49 questions. At 2 p.m. today, I tell why 49? This will be one question more. No, I will put one. I am thinking, what could be the question? I will put more. I am thinking with myself. Then I tell, okay, I will put this question as the last question for them. I wish it's easy today, but inshallah, if you repeat, it will be easy. Okay, this is the question number 15, last one.
30-year-old patient, para 0 patient, post-care accident 8 months previously and has paraplegia after the accident.
Post-car. I will correct it. Okay, post-car accident. Okay.
Okay. 30-year-old patient, para 0, post-car accident 8 months previously and has paraplegia after the accident. She is pregnant today, 8 weeks. How much DVT risk assessment score for this patient? Paraplegia. Para 0. For 30 years, score is 0. Para 0 score is 0. Post-car accident and paraplegia, I'll go with 1, score of 1.
Why 1?
Because she is having paraplegia.
So, or paraplegia will take score 1? All paraplegia will take score 1? Your answer correct. Your answer correct. I will correct this one because of the VDF.
Immobilization.
I will correct this one. Okay, it's a score 1. If patient paraplegia more than 6 months, the score will be 1 only. Like the other patient general population, it will be immobility. Immobility. Paraplegia more than 6 months. This is mentioned in TOG articles 2014. Pregnancy and the spinal cord injury. They mention if the patient after the first 6 months, the patient with spinal cord injury, she will have paraplegia. This patient, the thromboprophylaxis, if you look here, after 6 months, just you will follow the same general population. The score will be 1. So if you see one patient in the exam, paraplegia more than 6 months, or paraplegia for any maybe accident, maybe she has congenital anomalies like spina bifida and they have surgery before, so this will be score 1. So you need to assess the risk of thrombosis for this patient. So when you are seeing the patient paraplegia more than 6 months, how much is the score? You will put 1. And you will put assessment of the other risk factors, age, parity, smoking, whatever the risk factors in the question. But paraplegia only, more than 6 months, the score will be only 1. The source of the information. What?
What about paraplegia less than 6 months duration?
Less than 6 months, it's not mentioned in the guideline, but usually the patient, she will not never pregnant, in my opinion. I don't know if this can happen or no, but assessment can be done later, but the risk of will be higher. If patient first 6 months, it will be higher, but how much specifically, I don't know. But usually in the exam, because he wanted to check you if you know the guideline or no. The guideline, immobility in paraplegia more than 6 months. And he will not asking you questions like this. You get the idea? But he will know. He will check if you understand if the patient paraplegia more than 6 months, the score will be 1 or no. Usually you don't know this information in the exam, either part C or part 2. You will send patient paraplegia, you will give her low molecular weight heparin immediately. No. More than 6 months, the score will be only 1. Just the source of the information, this is reducing the risk of venous thromboembolism during pregnancy. This is April guideline, GGT, April 2015. And another also the peri-operative management of women on oral anticoagulant. This is March 2020. I think still you have enough time. Some they are thinking that they will fail in the exam. Why? Because they are thinking it's difficult. 1 month, I think you have almost 1 month, maybe less than few days. But you still in this 1 month you can pass the exam. This is my idea. If you are carrying, you study hard as possible as you can, you solve much questions as you can, you get every day more informations until the last day of the exam, you can pass. Still you can pass. I know some, they are preparing, but they are in the last months, they are very hard. They will be start working hard more and more. You should not give up at all, because there is hope, and hope should not lose at all. Now we can open. Anyone wants to ask questions? I wish everyone ask only one question, just one question, everyone, if we if possible.
Dr. Gada?
Yes, Dr. Nakhat.
Yeah, thank you so much for the session. But I think I got most of my answers wrong today.
You are the last one cheering? The last one?
Yeah, yes.
No, the last topic is hard. It's difficult for me, not for you. It's difficult. But this is very vital for the exam. Bridging is very vital for part 2 and part 3. I believe it will appear, if not in September, it will appear in next year. He will give you a scenario of patient anticoagulant rivaroxaban, and he will ask you when to stop. This is recent even talk articles March 2020. So don't worry. Your questions was the most difficult question today in the session.
Hello,
okay.
ma'am. Can I ask
Just
question,
one
Dr. Gada?
Yes, Dr. Salma.
Yes. For patient with comorbidity, before we are scoring 3. For sickle, F3 will give 6 weeks postpartum. For sickle cell, we said we will give only during admission and 10 days. What about other comorbidity like nephropathy, SLE?
Yes, I know this is much points in this like ulcerative colitis. Usually in the ulcerative colitis, you will give the patient from this will be score also 3. Usually they will give the patient with active flare, like ulcerative colitis. Okay, so this will be from 28 days. But if ulcerative colitis, she will have a score 3, but she is not active. This patient also, she will take a score 3, but she will not be received from 28 days, from 28 weeks. So like ulcerative colitis, she will take from 28 weeks and 6 weeks postpartum if she is inactive, if she has flare. But if she don't have a flare, usually they are not giving the patient with ulcerative colitis. Sickle cell disease score 3, but we are not giving except in admission, 10 days post-vaginal delivery, 6 weeks after cesarean section. Other cases, I know there is one much disease in between. It will be also assessment. He will put something making you choose. It will be all score 3, but he will guide you regarding the answer. The idea, Dr. Salma, in the exam, that you know how to do scoring, and don't worry, he will not give you something, but he will not give you something confusion. You get the idea? He will ask you regarding one of the important table in the guidelines table I put in regarding the risk factors of the students. Usually the questions will come from this. Okay,
Can
but
I
the
ask
idea
a question?
Yes.
Doctor, there was one question number 16, regarding this VTE. There was question that for venous delivery, that question, venous delivery, you scored 0, but in the chart, it is this mid-cavity rotational delivery or operative delivery. So my question is that the venous delivery is not included in operative delivery.
Why he didn't put in the guideline operative vaginal delivery? He can make it easy for us, and he will put operative vaginal delivery. So any forceps, any ventouse, but he put specify something only two, mid cavity and rotational. If you see in the exam any of these two words,
sorry. In the chart, it is written mid-cavity rotation delivery or operative delivery.
Not operative. No.
It is written.
Which question?
Please you check.
Which questions?
Yeah.
No, mid cavity.
Not all operative. Question number 16, but in the chart of VTE, where there is these risks are written, this high risk 3, where they are doing scoring. In their chart, it is written mid-cavity rotation delivery or operative delivery. So score is 1.
Like
No,
this one?
it is written rotational operative, not rotational or operative.
You see,
Yeah,
it's
mid
here. I think
cavity
it's
or
here.
rotational operative.
Rotational.
Or is
I
not
will.
written. Or is
No. Yes, it's here. You see, mid cavity or rotational. This is the complete of the word. Rotational operative vaginal delivery. This is the complete of the word. Sentence. Complete
Okay.
of the sentence. Okay? No problem. No problem. I understand you. But he put mid cavity or rotational. If he wanted to give us all, he will put operative vaginal delivery. Correct? So, but he
Okay.
put something on two, mid cavity and rotational. Okay?
Okay. Okay. Just I want to clear one point that this if only operative delivery is given. If only operative delivery, if vacuum delivery is given, so we will take as operative delivery or.
No, he should specify. He should specify. If he didn't give, so it will be score 0. Because he didn't give me what is in the exam. He can't give. He should give either mid cavity or rotational. Only you will put one. Other thing you will put 0.
Okay.
Or the
Thank you,
question,
doctor.
impossible to put question wrong. Impossible. Okay.
Doctor,
Thank
please
you.
clarify
Dr.
factor
Ghad,
5. Factor 5 lead-in. Can you please clarify homozygous, heterozygous?
Okay. Okay. This is the one in the factor V leading homogeneous type. We tell if the patient only she has this homogeneous, you will give her prophylactic dose during pregnancy and 6 weeks and involves the hematology. Heterogeneous, it's only score 1. So after delivery, if she has another one risk factor, she will be score 1 during pregnancy or after delivery. After delivery, either you will give her 10 or 6 weeks. So how I will choose in the exam? If she has only one risk factors, so only patient mobilization and hydration. If there is one patient with other one, so it will be 2. So you will give her 10 days. If there is a strong family history of thrombosis, you will give her 6 weeks. There is one Egyptian, I hear one Egyptian wanted to ask. Which doctor wanted to ask? Female doctor?
Hello, ma'am.
Excuse me, ma'am.
Nermeen, Doctora.
Hello?
Hello, ma'am.
Nermeen.
Hello.
Nermeen.
So we can take the Dr. Nermeen?
Yes, yes, Dr.
Yes, Dr.
Ghada. Only I
Nermeen.
want to ask in the flow chart for VTE risk factors, this postpartum, he mentioned that if a risk factor is persistent, we can give this patient for 6 weeks postpartum. I want to know only what is the meaning of this persistent.
You are talking about what?
A flow chart for VTE. The scoring.
You are persistent against the question, Dr. Nermeen. I didn't understand the question.
In the flow chart for
Excuse me, ma'am.
VTE,
Hello.
the risk for antenatal and postnatal. Okay, for the postnatal risk factors, he mentioned if risk factor is persistent, we can extend the low molecular weight heparin for 6 weeks postnatal. I want to know what is the meaning of this persistent.
No, the point, if you have score, you are doing a score. This score could be 2. If you have 2, sometimes the patient even 3 postpartum, she don't use before pregnancy. And during pregnancy, she didn't use any low molecular weight heparin. But by luck, after delivery, she lost blood loss more than 1,000. Whatever the risk factors, she becomes 3. You can give her still 10 days. But if she develop any other risk factors, like she develop appendicitis, any other risk, she need again reoperation for cesarean section, for example. She need prolonged. So there is another risk factors. So you can extend. Now you decide for the patient 10 days. But this risk factors persistent with the patient, and there is additional risk factors, you can extend the time to 6 weeks. But if the same risk factors, only 2, you can give her only 10 days, or even 3, you can give 10 days. But if there is anything developed new, you can extend the thromboprophylaxis more until 6 weeks.
Okay, Dr. Ghada, thanks.
Any more
Ma'am, excuse me, ma'am. Hello, ma'am.
Yes, Dr. Densha? Dr.
Dr.
Densha?
Ghada,
Hello.
question is
Hello.
regarding weight.
Yes.
In OHS,
Hello, ma'am. May I ask?
that the patient is pregnant, then we should continue this thromboprophylaxis for till 12 weeks. But it's not mentioned if the patient is not pregnant and she is having severe OHSS. So, for how long should we continue thromboprophylaxis in this case?
Ovarian hyperstimulation syndrome severe case in the first 12 weeks only, except if the patient she has another risk factors. But usually in the exam, he will put the patient with ovarian hyperstimulation to see when you need to give the patient in this case. Only in the first 12 weeks.
But if the
only
patient
for if the patient only for ovarian hyperstimulation syndrome, first 12 weeks only.
Okay, thank you.
Excuse me, ma'am.
Hello.
Any more questions? Doctor, yes?
Hello. Yeah, ma'am. In GTG,
Yes.
there are the two charts are given. One is showing the intermediate risk, high risk, low risk, and the other chart is about the scoring. So, which chart we should mark up? Because,
yes,
is it like that in antenatally we have to calculate the score, and the score postnatally also will be different. So, we have to calculate it again.
The first table in the guidelines, I know what you are meaning about. This is one chart about intermediate and high risk. The first important point in this guideline, how you are going to do scoring. Usually in the exam, I will tell you, usually in the exam, he will give you two questions from the table I put. The one very high risk, and the patient with low risk. And there will be another questions about scoring from the 1, 2, 3, 4. There will be one question from this one, and there will be one question from this one, plus the antiphospholipid syndrome. Not to be confused regarding the antiphospholipid. Just you are seeing antiphospholipid, you will give all. You don't know that antiphospholipid antibodies only, no need for anything, because it will be risk factor is only one. If you are giving for recurrent mistakes, this will be a specific low molecular weight heparin you are giving for specific duration. If for venous thromboembolism, you are giving a high prophylactic dose and during pregnancy. Okay. So the point, don't be confused. Don't be confused. Just follow the important informations in the box, because this will guide you to the important informations. I know that there is parts of confusion in the guidelines. Even until you finish the exam, there is the part of this confusion will be continued. So the point here, I wanted to just put rules. If I know the essential parts for me for the exam, how I'm going to, because even the point in the exam, if you are going to give a score, you are giving the score wrong. Patient hypertension, you are giving in the exam score 1 and the hypertension 0. Patient with previous stillbirth, you are giving in the exam score previous IOPD, you are giving the score 1, and it should be in the current pregnancy. So don't think that they will put very difficult question for you. No, they will put for you very simple question, and in the exam you can't answer this question even it's simple. Just I will mute again all. So my opinion, try to be simple. If you know the basic points in the guidelines, this is very enough to pass the exam. But if you increasing more and you become more confused, I know there is parts of confusion there. You can even the simple question, you can answer it wrong in the exam. Thank you for all of you. I will post the record, inshallah, in the group. If you have any more question, just if you have any more question, if possible, you can post in the recalls group. Okay. If possible, okay, and I will answer it soon, inshallah. Thanks a lot for all of you, and thanks a lot again. Try to continue again. Still, there is hope that you.
Can Dr. Ghada please also you post this PDF?
Yes, I will post. I will post after the session, inshallah.
Thank you, Dr. Ghada.
Thank you so much. Goodbye.
Thank you.
Goodbye.
Thank you.
Goodbye.
Thank you.
Thank you. Goodbye.
Thank you.